Hello, everybody. Hope everybody's doing great tonight, today, tomorrow. I know we've got people from all over the world joining us. Welcome to today's, Dr. Contreras is here. Welcome to today's edition of our weekly or bi-weekly webinar. My name is Gaston Tecada. I'm the director here of Oasis of Hope Hospital. We're going to get started in a couple minutes. Why don't you do me a favor, everybody? Why don't you give us your name and where you're from, and so we can get started. Thank you so much. We're going to get started in about a minute or so. Also, in the meantime, today's webinar is going to include a short presentation by Dr. Contreras and Dr. Cecena, and we're going to have a live Q&A. So if you have questions about your diagnosis, about anything that we do here at Oasis of Hope, please feel free to start asking the questions. So when we get to the live Q&A, we will get to your answer as quickly as possible. So why don't you give, also we got Karen from Knoxville. Hi, Karen. Monica from Virginia, Tasha from Sacramento, Terry from Florida, Nina from Arkansas. We got Graznia from Australia, nice. We got Alicia from Mexico. We got Peter from London. We got a very international audience today, Mr. Dr. Contreras. Why don't you come on over, Dr. Contreras?
Spread all over.
Muy bien, ¿tú?
Bien, gracias.
We got Christine from Arizona, Christine Russ from West Virginia, Basha from Arizona, Sheila from Minnesota, Brenda from Eugene, Oregon. That's where Nike is, right? Janice from Colorado, Mary from Pennsylvania. So why don't we get started, Dr. Contreras? Thank you so much for joining us today. Well, welcome to our latest edition of our monthly and weekly webinar. It all depends. My name is Gaston Tecada. I'm the director here at the Oasis of Hope Hospital. I want to welcome you from all over the world, whatever time zone you're in. Welcome to our webinar. Today's webinar, we're going to focus on a live Q&A, and we're going to just ask Dr. Contreras and Dr. Cecena to discuss a little bit about what you should be asking your oncologist if you have been recently diagnosed or have been fighting a diagnosis for a period of time now. From a surgical oncologist point of view and an integrative doctor's point of view, Dr. Contreras is the medical director and president of the Oasis of Hope Hospital, and he has been treating cancer patients for more than 40 plus years now, and he is an expert in the field. And Dr. Francisco Cecena is the director of oncology here.
I joined him 32 years ago.
32 years ago. So there's a lot of cancer wisdom today in today's webinar. And Dr. Cecena, thank you for joining us this week. It's always
my
good.
pleasure.
Dr. Cecena, he heads up the follow-up department here at Oasis Hospital. I don't know if any of you guys have had the pleasure of knowing him, and he's great with our patients. And the follow-up program here at Oasis Hospital is a department designed to keep in touch with the patient once they're discharged from the hospital. And Dr. Cecena has been gracious enough to join us today, and we'll get started. Like I said, during the presentation, I will invite you guys to ask your questions. Take advantage of this hour that we have Dr. Contreras and Dr. Cecena. Ask your questions about your diagnosis, about what you think about our treatments, about vitamin C, about our dendritic cell therapy, immunotherapy, hyperthermia, anything you want to know from our expert panel here. So I'll give Dr. Contreras a couple of minutes to discuss the questions you should be asking your oncologist or your medical practitioner with a recent diagnosis or with a diagnosis you've been struggling for a while now. So take it away, Dr. Contreras.
It's an honor to be with you. Thank you very much for joining us. The theme of what to ask your oncologist is a complicated one because doctors are not used to being questioned. And especially if you want second opinion, usually they will they will be okay with you asking for a second opinion, but usually the second opinion is going to be very similar to the first because they are not open to any other venues. I think that in order for you to ask pertinent questions, you need to be a little bit informed, and the information is so vast and so confusing that it's just difficult to create an environment of where you can have an honest and open conversation with your doctor, where the doctor, he or she, will not just obliterate you with his or her knowledge and their point of view. One of the things that I found to be helpful is to have some pertinent information, and for that reason, I wrote this book, The Art and Science of Undermining Cancer, where I expose and give information about everything that is conventional and about the possibilities of non-conventional therapies, and where I also let you know that just because it's not conventional or not approved does not mean that it doesn't have a scientific basis for it. And so everything that we do here at the Oasis has a tremendous amount of scientific support behind them. So be well informed so that you can ask pertinent questions. You know, if you ask your doctor, "What's my prognosis?" It's usually, you know, a question that is going to be answered, "Well, you have 1 year, but if you do chemotherapy, you might have 2." And that type of information can be very devastating. So we're not gods. We don't know how you're going to do. There's miracles that happen. There are patients that are thought, you know, from scientific point of view, that the prognosis is very poor, and then the patient survive for many, many years. So it's a complicated issue on what type of questions you would ask. You know, some patients sometimes want to know if that is really the best treatment for you. And one question that comes to mind is, would you do it yourself if you were in my shoes? That's a good question, but one that I'm not sure that is going to be answered completely openly. So it's a little bit difficult, but the more informed you are, the better questions you can ask. You know, is this the best for me? Is the prognosis really going to improve? Do I have alternatives? Usually that's going to be no. But let me tell you that there's always a choice of things that you can do and that you can do differently. Sometimes the conventional way is the best way, especially in early stages where surgery can be extremely effective. There are some tumors that respond very, very well to chemotherapy. And if you're against it, and let's say you have a Hodgkin's lymphoma, and the doctors say, well, the best choice for you is chemotherapy, and if I was myself, or if I had a daughter, I would give it to her. That's probably true, because about 90% of the cases, no matter the stage, you will have good results. So it's a little bit complicated. What do you think?
Well, confidence and trust is always is at a crisis, and people who people who ask questions generally, in our experience here, the more questions that a patient asks, the more likely they're going to escape pitfalls. That is the basis of second opinion, but a second opinion within the same orthodox realm is probably going to give you the same answer. So that's why, you know, you need a trustworthy source of information that may give you more choices, and then you can ultimately consider all your choices and select the best treatment. What you want to have when you're undergoing treatment is total, well, as much as you can have, is total peace of mind, peace of heart. Don't be looking over your shoulder when you've selected a therapy because, well, that doesn't contribute to a good outcome. So, you know, at Oasis has been here for 65?
62 years.
62 years. And so, you know, we have a very very long history and mountain of experience, and we're always willing to, even if you're not going to come to the hospital or do our therapies, we're always willing to help, to give you some guidance, to give you some points that you need to know before you undertake a treatment that sometimes is not the best choice for you.
Yes, I'm sorry that for a theme as complicated as this, we don't have a cut and clear indication of what would be the best questions to ask, because it's just so, I mean, there are so many variants from cancer to cancer, and even from the same cancer. Like breast cancer is not just one type of breast cancer. It's a whole family of tumors. So again, I think that information, being well informed, is the best for you. And one of the ways is to find some books instead of just the internet, because that can be very complicated. So I would guide you again to my book, The Art and Science of Undermining Cancer, where I openly talk about the benefits and pitfalls of both alternatives and conventional therapies. So with that, we would like to start receiving your questions. And so I'd like Gaston to come back.
So we're gonna go. Thank you so much, Dr. Contreras and Dr. Cecena. It's a tough subject.
Yes.
What to ask your oncologist. I know that we at our admissions department, we get a lot of questions from patients. And give me a quick question before in the meantime, if you want to start asking your questions in the Q&A section or the chat, they're very welcome. They're filling up really fast, so take your time with your questions. We'll be happy to answer them. The question: physical condition of the patient is something that we always ask our patients. Why is it the physical condition of the patient so important to the doctor, for you guys in particular?
Well, the main reason for that is that our treatments, even though they are mostly natural and generally very, very, very well tolerated, it's a you know, straight fight against the tumor that can take a toll on a patient's well-being. And if a patient is in a very dire condition or has kidney failure or liver failure, they may not be a good candidate for our therapies.
Okay.
So it's important for us to know you know, the general condition of the patient and how well the organ functions are, so that we can openly tell you, yes, you're a good candidate for this therapy or not.
To tailor the therapy depending on patient status. You know, not, you know, depending on your situation, you may or may not be able to do certain therapies that we want to bunch up against cancer. So we always are making sure that we understand what your status is, so that we select the best bunch of therapy, because bunching up is the key to beating cancer. And so selecting the correct bunch is our first step.
That's a very good observation, because the way that I stated, it was an either all or none. And no, depending on your condition, we can tailor the treatment to your needs and how well you can tolerate that. And we can then get you to the next step by improving your general condition. So thank you for that clarification.
I appreciate it. That's a great thoughts. I appreciate that. So we're gonna get started with a live Q&A. We had a lot of questions, but before we start, I want to give a shout out to Michelle Tucker.
Oh,
My
hi, Michelle.
My favorite doctors. Hello, it's Michelle Tucker. Thank you so much, Michelle. We miss you, and we are always praying for you, Michelle. And great success story of Oasis folks.
Yes.
So we love her. I'm gonna ask this question, and we get this question every day. Fenbendazole, ivermectin. What's the research for fenbendazole, ivermectin? Deborah is asking.
There's quite a bit of research behind them, especially on fenbendazole, and it does have some anti-tumor effect. but we offer much more effective therapies here at the Oasis of Hope. On ivermectin, there is definitely research that shows that it can have some anti-tumor effect, but there's a lot less experience with it long term. So what a good number of our patients want to take ivermectin or fenbendazole, and what we advise is for them to comply with our therapy 100% because it's very comprehensive. There's a lot of elements. Tolerance is a major issue. And once a patient tolerates and complies completely with our therapy, if they still want to add ivermectin or fenbendazole, we ask them to consult with us, and then we'll let them know if it's a good idea or not, or if it's necessary or not. Dr. Cecena is one of the themes that is constantly talking to and with the patient.
So consider the principle of multiple therapies or synergism working against cancer. You take any of the elements in our therapy and put it up against cancer as a single agent, it's probably worthless. But you take it and you put it in a group of therapies which are working with each other and for each other synergistically, then you get the results that improve upon multiple drug chemotherapy regimens. So the same applies for fenben, the same applies for ivermectin. They're good helper elements, they're good associative elements, but they are not good single elements. You're taking a risk in placing such a big responsibility on a single element of therapy. We never depend on a single element of therapy to beat cancer. We always bunch up against it. And fenben and ivermectin is part of our patient's approach, and many times because some patients will not take no for an answer.
and it's not going to harm, that's for sure.
That's great. That's great. Continuing on, I don't know your first name, but last name, Sarna. What kind of treatments do you offer? Inpatient or outpatient? What is the cost? Treatments will be covered throughout the webinar, so we'll answer those questions throughout this hour. Inpatient or outpatient? We are inpatient and outpatient. Most of the patients that come to Oasis of Hope are inpatient. Follow-up patients, if they are cleared, can do outpatient, but most of the time we do an inpatient. Patients eat here, they sleep here, they get treated here, they get hugged, but they're loved. So the support is here. So inpatient, hospital setting with a hotel room vibe, if you want to put it that way. And the cost is tailored, is personalized. So contact our admissions office. And what we will do is that we gather all your medical records and we give them to Dr. Contreras and the team here, and they design a personalized treatment plan with a Zoom consultation for you also. So all patients that are interested get a free consultation via Zoom by one of our admissions doctors, no cost. So Janice, let me see, I lost you. Janice is asking, how do vaccines work in the body? Great question, Janice.
Well, the classic term applies to infectious diseases, and what happens is that a germ will come into your body, and if you survive it and able to control the disease, your body will keep a memory of that foe, of that agent, so that if you are exposed to it again, your immune system has experience and can combat this agent, avoiding the infectious process again. So in a very simplistic way, that is the way vaccines work. Now, vaccines against cancer are a little bit different, but the term vaccine was used by the developers in the late 90s and early 2000s. In fact, two groups obtained Nobel Prizes of Medicine for this development of vaccines against cancer. And so what we do in that case is expose the immune system to the tumor's antigens so that the immune system develops a task force to combat the cancer. It's a very personalized, very effective type of therapy. There are several variations to the therapy, and I want to let you know that because of all the new developments that they're doing, our immunologists and lab technicians working at the laboratory, we are calling now our protocol IMPACT. Immuno, P, personalized, A, autologous, because it's from your own blood, C, cell, T, therapy. IMPACT, our immune therapy, IMPACT. With a P is personalized.
Oh, I'm sorry.
Okay, so this is a new name, so it's new for all of you, and
There's always a refinement going on at Oasis.
Yeah.
That's a feature of the hospital. We're always improving. We're always making our treatments better.
and so this amplified.
But that's Dr. Contreras' passion, by the way.
It is, and so this broad name encompasses all of the variations of the dendritic cell-based immunotherapy. So, in a nutshell, we create within the patient an anti-tumor task force very specific for that patient and very specific for that tumor. And that's the way vaccines, cancer vaccines work. There is a vaccine that works more or less in the traditional concept of vaccine that was developed for cervical cancer in women that is applied to young women, and according to the literature, it has been quite successful. But that's the only vaccine for prevention that actually exists. The other vaccines that we're talking about are for treatment purposes and not for preventive purposes, as most vaccines are used for.
My concept in regards to the dendritic cell vaccine, which is what we do as a main element of therapy, is that vaccine is a misnomer, because what we're actually doing is a enhancement or augmentation of a natural process. People think that, or many people think that cancer is a disease of a failed immune system. It's not. It's that your immune system perfectly normal, but it has not identified the invader. And that's a feature of cancer. It can evade detection. So what we're doing is to unlocking or unveiling the cancer to your immune system, opening the eyes of our immune cells to the invader. And that's something that we do through, we're doing immune augmentation. We're doing a natural process. We're just multiplying it, so to speak.
Correct, and that's why we are, let's say, improving on the terminology, because it is not really a vaccine in the traditional concept. And the main reason why our immune system doesn't see the tumors for a long time is because malignant cells arise from benign cells, from normal cells, and they mutate. And so for a long time, the immune system will not consider them as foe, and sometimes never. And that's why creating this unveiling type of treatment to improve the capacity of the immune system to attack the cancer is so important and has been very effective.
A famous oncologist in the 50s said that the best chemo was the one that would kill your right ear and not do anything to your left ear. So that's selectiveness, but that also attests to how similar cancer cells can be to normal cells, and that's why cancer can evade detection of our very efficient immune system.
That's great. That's good information. Let's go on to our next question. lot to take in. Alina, I can only see very few recordings of your webinar on your YouTube channel. Yes, you can. On YouTube channel, they're kind of limited because of the information, but all of our webinars are on our Facebook page, and we are coming up with a new website in about 3-4 weeks, and it's going to have a webinar section so you can view them all there. But you are right, it's not all of them on our YouTube page, but they are all on our Facebook page. So if you want to go to Facebook, go to the videos and you'll see them there. We have around about 6 webinars that are posted there, and this one will be posted on Monday.
Is the main reason that
Well, some
they
platforms,
cancel us?
some platforms are very wary about the information you put on there. So yeah, so
Yes.
we're trying not to get canceled. So
And for instance, one of the words that they're canceling us for is just the word vaccine.
yeah, not even associated with cancer. It's more of for the COVID.
Yeah, just yeah.
Exactly. So yes.
So we're gonna be able to evade the detection?
By using what word?
Impact.
Impact. There you go. There you go. Took a while to develop that word, but we I like it.
It's a good.
I like it.
The word was there, just waiting to be.
Right, it was waiting to be properly used.
And it's an acronym too. That's what I like about it. A quick question from Ava. It's a question we get a lot. Is hyperbaric treatment available in the basic treatment plan of Oasis? And it's something that we do. We always get. Why don't you guys use hyperbaric oxygen or hyperbaric chambers? And but we use ozone.
It's a very good question. Now, patients that come to Oasis for alternative therapies generally have to pay out of pocket. And so we are always conscious of that fact. And most of the patients, when they make a decision to come here, they've been dealing with cancer for a long time, and they've spent a lot of money. So one of the reasons why we do ozone instead of hyperbaric chamber is because of the cost. So ozone does everything that the hyperbaric chamber does, except for the getting rid of nitrogen in divers. So if a diver comes up too soon and has problems, the ozone therapy is not going to resolve their issue. Those patients have to go into a hyperbaric chamber. But cancer patients will get all the rest of the benefits, which is hyperoxygenation and oxygenation of the malignant tissue, which is so important in developing treatments for cancer. So most of the treatments that are effective in destroying cancer are oxidative. In order to oxidate, you have to have oxygen. And tumor tissues protect themselves physically and chemically against oxygen. So they're oxygen poor. And thus the oxidative therapies like radiation therapy, many chemotherapies, or vitamin C will not work. So ozone therapy has proven to increase the amount of oxygen in tumor tissue. I don't even know if there are studies on hyperbaric chamber, but I would imagine that hyperbaric chamber will increase the amount of oxygen within tumor tissue. But ozone does, and that is why we choose to do ozone therapy rather than hyperbaric, for cost and because there's literature, there's scientific studies that prove that ozone increases the amount of oxygen within the tumor tissue.
Yeah, and one of the things that always kind of catches me is that hyperbaric oxygen, the chambers, they're the zipper kind, and they're the Michael Jackson kind where he slept. I mean, there's by atmospheres, right?
Yeah. So
I mean,
the most common that people have at home, they only have about 1.5 atmospheres, and that is not sufficient really for therapeutic use. It may be good for preventive or for rejuvenation, just to oxygenate your body a little bit more. So 2 or more atmospheres are what is needed for true therapeutic effect, and those are more expensive, and they need more monitoring of the patient, and so those you cannot do at home.
Great, great. So about four, what do you call them? Four death zones, right?
The atmospheres?
Atmosphere levels. Yeah, that's what I've kind of heard that.
Yeah,
The
4 is a little bit
minimum,
high.
a little bit high.
No, 4 is a little bit. I think 2.5 is the minimum.
2.5 is the minimum.
3, 3.5, and 4
That's where you want
are,
to be.
yes.
Okay, got it. Right, let's continue on. Thank you for that question. Nina Vargas, it's a long question, bear with me. I was just diagnosed with invasive ductal carcinoma grade 3. I do not have an MRI done yet, and I don't have the stage of my cancer yet. I've had 2 samples taken for biopsy, one from my breast and one from my armpit. They both came in as cancerous. I was told that most likely once I see an oncologist, they will want to start me on chemotherapy, followed by surgery later. I'm not sure what I should do. What's your best opinion?
The first thing that you need to do is a PET scan to determine whether this is a regional problem or a systemic problem. If it's regional, you would be called a stage 3, which is very different than the grade. Okay, so if it's 3 out of 3, you have a high grade. If it's 3 out of 9, and your pathology has to determine that, then you have a low grade with much better prognosis. It's also important to know if your tumor is hormone dependent or not, if it's HER2 positive or not, in order to design the best therapy for you. So if they want to do chemo, it's very likely that they believe that you are in stage 3, and with chemotherapy, they want to convert you into a stage 2 or 1 so that surgery can have a higher possibility of curing you. Now, our experience in stage 3 and even stage 4 breast cancer is vast, and our neoadjuvant therapy, or therapy that will prepare you for a better for you to be a better surgical candidate, is very good, much better than with chemotherapy. And so I would ask you to consider coming to the Oasis of Hope for treatment. But the first recommendation that I'm going to do for you is to do a PET to determine more precisely determine your stage.
Your doctor may select another imaging modality such as MRI or CT scan, and that works too.
Yes. PET is the best, but just to find out if there's any tumor activity outside of the region, outside of the breast and the axilla.
Perfect. Thank you, Nina. If you have any questions, feel free to contact our admissions department. We'll be happy to help you. Kristen is asking about dendritic cell vaccines and therapy. I mean, we kind of went through that. This says, how often would a person need to come back to the hospital for additional therapies?
Okay, again, cost is a major issue. And so we request that our patients come at 3 months, which is a very good time to evaluate how effective our therapy is, for us to evaluate if we continue with the same therapy or make any modifications. Most of the protocols for dendritic cell vaccine in America do repeat the vaccination much more often than we do. It's about every month or every 3 weeks. And so there seems to be an advantage. The more vaccinations you do, the better the results. And we are working diligently to make that available to our patients at a reasonable cost, because the main reason that people would not be able to do that is the cost.
And the travel and everything. So,
yes.
Yeah.
But hopefully very soon we'll have, we're developing a protocol here at the hospital where we can have more, at least a vaccination a month at a reasonable cost. And we believe that it would be more beneficial to the patients. But right now, we've been doing this for many, many years at 3 months intervals. If the patient does well, then we go to 6 months. If the patient continues to do well, then we do once a year for 5 years. And if a patient is stable or with no evidence of disease at that time, then the patients do not need any more vaccinations.
Anything to add, Dr. Cecena?
Well, again, it's on a patient to patient basis. It's tailoring. Not everyone needs to come that frequently, the better the situation of the patient is, the longer the treatment interval will be. But we're always thinking about what's convenient. We don't do all cookie cutter treatment. Some people are how do you say, need to come every 3 months because of the nature of their disease, and some people can stay away for a full year.
Great, great. And yeah, I mean, it's the immuno lab that we have here at Oasis. We should do a live webinar from the immuno lab,
Yes.
so you guys can see the installation it's fantastic. It's very state of the art, and we're doing pretty soon we're doing cryopreservation of the immunocell therapy, not to say vaccines, impact therapy. So we'll keep you posted on the developments. That's a great thing about Oasis. We'll constantly develop new treatments, new strategies, and
Well, as the vaccine as planned is not only going to be cost effective, it's a treatment upgrade.
yeah,
But we need to understand that we've been doing pretty good so far, even with what we've been doing.
great, great. And Michelle is saying you look fantastic. Is that me, right?
No, it's me.
Contreras?
Yeah, not yet.
Cecena. Well, we miss you, Michelle. When can I come back? How is Michelle doing? Is she nervous?
Michelle,
As much as we want to see you here, I think
Yes.
you can stay away.
if you want to come to
Yeah.
to visit with the patients, encourage patients,
Yes,
the doors are always open for you. But thank God, apparently you do not need any more treatment.
that's amazing.
You
That's
wanted to stay that
amazing.
way.
And they're all miracles, right?
Yeah,
They're all miracles. Dr. Contreras says we're good, but we're not that good. That's always
exactly. God is great.
God is good always, and let's always give him the glory. So this is a follow-up question from Bendazol. I love these questions. We get so many questions from Bendazol. So if I want to go to Oasis, do I need to stop taking Bendazol?
No,
No, okay. Or ivermectin? No,
No,
right? Okay.
no. There's a very good question there.
Which one?
KM, Kevin.
Kerwin or
Yes,
Kerwin?
Kerwin.
Why don't you treat non-Hodgkin's lymphoma?
That's
Kevin.
a very good question. So we are open to alternatives when the conventional option is of very little or no value. Why are there no alternatives to appendectomy? Have you ever thought about that? Because it works almost 100% of the time, the appendectomy resolves the issue. So Hodgkin's lymphomas, and in fact, most lymphomas, have an extremely high cure rate with conventional therapy. And so there's no need for an alternative because it works very good. So overall, our results in all cancer source, all stages is about 30%. And so let's say that in lymphomas, we would be 60%, but chemotherapy is 95%. So I would not offer you a lesser therapy for that. We've had some patients that say, well, I'd rather die than take chemotherapy. I remember a parent brought his
Child.
16
I think he was younger.
or younger,
Mhm.
and he was adamant. And we came to the point of telling him this for us is not ethical, and we will not abide by your wish because we feel that the best for this kid is the conventional therapy. And thank God, finally, we were able to convince him. The boy is completely free of tumor
That's
activity.
because he was a kid, but we will treat a patient. If you'd rather die than do chemo, then you better have a good alternative.
Mm-hmm.
And our treatment has been a good alternative for those patients who will not do chemo for any reason, and some of them who have failed to chemo. So, but given, as explained by Dr. Contreras, we'll never offer our therapy over something which we know has a better possibility
Exactly.
that to treat for a good outcome.
And now, in that 5 to 7% of people that do not respond, then our treatment is a very good alternative. Or if the chemotherapy was able to reduce tumor activity, let's say by 90%, but not 100%, then that's a very good alternative. There's other two aspects that we do offer is in patients that did not achieve complete remission or have a recurrence, then our treatment is a very good option. The other is that we do what is called a preconditioning program, where we prepare our patients for chemotherapy so that the results are even better and the tolerance is better. So that program, those two programs we do offer to patients with lymphoma. So it is not that we never accept a patient with lymphoma. It's just that we believe that conventional therapy is the first and best option.
Going back to the, it's an interesting way that this boy's father, who was very, very adamant and convinced that he would never do chemo for his kid, and we couldn't really convince him to the contrary. So he finally understood when he was given an illustration, and he was walking, and the example of him going walking with his child, and he's carrying a high-powered rifle on his right shoulder and a little 22 caliber gun on his left hip. So she was told, what if a wild lion, a beast of a lion came at you running? So which weapon would you choose to shoot at it? And he immediately said, well, obviously the high-powered rifle. And he said, well, that's chemotherapy, and what you have on your hip is the Oasis therapy. And so he understood that in that manner. And so fortunately, and we know for a fact that the boy is doing very well.
Great. We have a lot of questions to get to, so we're gonna try to power through them as quickly as we can. I know that everybody has a interest in what Dr. Contreras and Dr. Cecena have to say. Andrea Arce is asking, I have stage 4 breast cancer. Andrea Arce, after double mastectomy, now I have 7 nodules under my skin and laying on the sternum. Do you ever use methods to shrink the tumors?
Yes. Yes. In fact, what is happening to you is very common, and our results in patients like you have been very, very good. So I do encourage you to consider our program for you.
Yeah, Andrea, give us a call, send us your medical records, and we'll be happy to help you. Terry's asking, what's the difference between your clinic and immunity therapy center? Why should I choose their center over? Oh, yours over there. Okay, ITC, they're a great clinic. They're more of a clinic, not a hospital. I mean, don't want to throw stones in glass houses.
Yeah.
I mean, they're a great center.
I think the advantage that we have is we have a lot more experience.
Yeah.
Our treatment is more comprehensive. As Dr. Cecena was saying, depending on one element, even depending just on the vaccine, is not a wise thing to do. It's better to attack the cancer from different flanks. So our protocol is a little bit more comprehensive. We have oncologists on staff so that we're able to see from both sides of the aisle, so to say, from the conventional and the alternative, to choose what would be the best for a patient. And just the amount of patients that we've treated over the last 60 years.
60 plus years operating.
Over 100 and some thousand patients. It gives us a lot of experience.
Most of the doctors around Tijuana, they started working here.
Yeah, most of the directors of the competition are alumni of the Oasis. Not all of them, but a good number.
But yeah, they're all good. But Oasis is something different. I mean, something special about the ambiance here. Great thing about Oasis is that you stay at the Oasis the entire time, and there's a lot of cancer wisdom running through the halls of Oasis. There's a great community that's developed here, long-time friendships and spiritual support. We have a pastor on staff, we have psychologists on staff, and we have 24-hour nursing, 24-hour doctors. So that's a great thing about Oasis. Moving on, can you spell the name of the vaccine that you were talking about, please? Yeah, it's dendritic, dendritic, dendritic cell therapy. Let's go to some of the Q&A questions. Let's see. Okay, we go. My brother has been diagnosed, Aiden, my brother has been diagnosed with stage 4 small bowel adenocarcinoma with peritoneal metastasis, moderately differentiated MMRP and HER2 negative. Oncologists here now then told him that they do not think it's curable. What do you propose?
Well, by definition, in conventional therapy, stage 4 cancers are not curable. So that don't be afraid of that term. Small bowel adenocarcinomas, the good thing is that it's moderately differentiated. That means that the rate of growth is not so fast, it's not a terribly aggressive tumor, but they are difficult to treat because they respond poorly to conventional therapies. And I think that our protocol would be a very, very good option for this. Seems to me young
It's-
man didn't save the.
Yeah, it's Aiden Ryan, his brother, so.
Yeah.
Mhm.
So I think that your brother would be benefited by sending his data to us. We will evaluate it and we'll send him a proposal of a therapy here at the Oasis.
Perfect. All right, let's give Dr. Cecena a chance to answer a question. Do you have good results with HER2 negative with PLK3CA mutation at your facility?
BRCA.
BRCA. Was that BRCA?
HER2 negative.
Oh, no.
With
PLK3CA.
mutation.
Well, it turns out that HER2 negative is actually easier to treat than HER2 positive.
Yes.
And PIK is a mutation that you can take advantage of therapeutically, but it's usually not a first-line therapy for us. The therapy such as we do it is usually enough so that you can keep any other therapeutic resources in reserve. That way, if our treatment is very helpful to you, you keep therapy options in reserve. If our treatment helped for 3 years, 4 years, 5 years, then if you need something else, then you'll have something else to further extend your survival. So, I would consider your situation or that situation a very good treatment setting for us.
What Dr. Cecena, sorry, is referring is that mutation that you have has the possibility or opens the door for you for some targeted therapies. But you can keep those under the sleeve, so to say, if needed, because with our program, patients like you have responded really, really well.
Great.
And consider a stepwise approach. You never, if you want to take the first step, and if that's enough, you don't have to climb up the ladder. You only climb up the ladder on an as required basis. So we expect that we're going to help you on the first step, and then everything else can be kept in reserve. That's a rational way of using your therapeutic options. You administer your options in the best possible way. You don't bunch them up immediately because then you'll have nothing left to use if you need anything else.
Perfect. All right, why don't we let's go with Bashi. She's asking, what would be one question that I would have asked if you wanted to find the best option for your mom if she has stage 4 colon cancer? She is 88 years old and no symptoms.
Well, then, a very good option would be ours because chemotherapy has not proven to be very effective in colon carcinomas. And it is very harsh and would be very devastating at your mom's age. So definitely a protocol like ours would be much, much better for her.
In Spanish, we have a saying, mírame y no me toques. That means look at me, but don't touch me. So an 88-year-old should not get anything aggressive. We can do therapies that are mild enough that an 88-year-old would tolerate very well and would have good chances of benefiting from. But within the orthodox realm, there's nothing safe and very useful for an 88-year-old.
All right. Let's see, Mark is asking, the only part of the home protocol I didn't do was the sodium bicarbonate. This is a question for Dr. Cecena, because he's part of that. I need to get with the program. See you on February 10th. So is that a question? What is the Facebook page? The Facebook page, Eartha, is Oasis of Hope Hospital on Facebook. Just put it on the search tab. You'll find it really easily. Wendy's asking, what other choice do we have if the glioblastoma has been surgically removed twice and now my husband is having chemo and immunotherapy, but I don't feel that there's any improvement?
Well, we have been treating patients with glioblastomas after surgery and chemoradiation effectively. They're very difficult tumors to treat. They're very, very fast growing. And I think it's worthwhile trying. We've seen some good results with the vaccine. We have some patients that were told that they're going to die in a few months, and a couple of years later, they're still alive and doing well. So it's worthwhile trying.
So that's a situation that describes what we've been discussing. We would not take a patient with GBM for our therapies as a first choice. We would probably be told to go get surgery, maybe radiation therapy, and then we would try to maintain the gains that those therapy measures. If all those therapy measures have been used and have not worked, then our therapy is a worthy effort to try and keep the cancer from growing.
Great. Lynn Barber, you have an interesting question. Your discussion regarding the need for the PET CT scan to consider the progress or status of the cancer. Oasis requested that I get a PET and submit to the hospital for determination of a proper protocol. However, both my oncologist and surgical oncologist have indicated that my appendiceal cancer doesn't show up on the imaging. So
it's a mucus producing cancer has a very high rate of false positives.
That's true.
Yeah, so what would we need in order for imaging for us to give her a recommendation?
CT or MRI.
Yeah.
Okay, Lane, I'll ask our admissions department to contact you also, and just a CT scan. Okay, all right, CT scan would be great. Thank you. Andre Arce, got my appointment tomorrow. Great. Misty, stage 4 breast cancer that has metastasized to the eye. I'll see a specialist in a week. Do you have any recommendations for treatment?
That is extremely rare. I think that one of the things that your oncologist will do is to determine whether that's a second primary or not. It can happen because tumors have no word of honor, but it's just extremely rare to have metastasis to the eye. And so I would seek an opinion to determine precisely if it could be a melanoma or a second primary or not.
Okay. Brenda's asking, colon cancer with mets to both lungs. Stopped chemo a year ago, but tumors are growing.
Yes, so you are one of the typical cases where our protocol would be much better than going into a second-line chemotherapy. So if you had FOLFOX, now you're going to be offered FOLFIRI or FOLFIRINOX, which are a lot more toxic, and the results have not proven to be any better. So you would be a very good candidate for our therapy.
And also, if you do second-line chemo and fail to it, by the time you ultimately choose to do alternative therapy, you will be sicker. You will be the worse for it. And so ideally, the order of trial is naturopathic first and keep everything else in reserve.
Great. Okay. Christine Wilcox, this is a question for doctors, for you guys. How often do you recommend doing coffee enemas? Are they recommended for a person with upper rectal cancer?
Well, coffee enemas are for detoxification. If you keep a good diet, you do not need to do coffee enemas. We do them here once a week. I know there's, on the old protocols for the Gerson, some people do it 3 times a day, and I think that's a bit too much. Maybe once or twice a week, if you feel that you need to detoxify, that would be, in my opinion, more than enough.
Right. Monica is asking, Maya, I'm not interested in Western treatment. That's why I haven't returned to see a regular doctor since the breast diagnosis in 2021. I don't have any recent blood tests or tumor markers, but I feel good, but I think my breast has a fungus type of disease.
I would urge you to, if you don't want to see any doctors, I don't know how far away you are from us, but then come and see us, because if you have a fungating tumor, I'm not sure that that is what you mean, but if the tumor in the breast is growing, well, we need to start doing something so that it doesn't get out of hand. And our results have been very, very good with all types of breast cancer. So if you feel uncomfortable with conventional medicine, please come to us so that we can advise you on what to do in order to keep this tumor away.
Thank you, thank you. Alicia's asking, how do you think about success rates? What are your success rates of your therapies? Do you track them, outcome of statistics, and do you compare them to standard therapies only approaches? I imagine what you're saying is your success.
Yes, we have been able to do
therapies.
prospective clinical trials on 4 types of cancers. Doing prospective clinical trials is very expensive. We're a small entity. We have no backup. We're not backed by any type of institution, and that's why it's almost impossible for an institution like ours to do prospective clinical trials. And yes, we compare them against the literature. So, for instance, we did a prospective clinical trial on lung cancer. In comparison to conventional therapy, the end results are that our therapy is virtually 9 times better than with conventional therapy. In ovarian cancer is about 2.5 to 3 times better. In colon cancer is 2 times better than with conventional therapy. In breast cancer, patients that had chemotherapy, radiation, or any type of therapy before they came here is about 3 times better. But if the patients come virgin to treatment to us, the results are 5 times better than with conventional therapy.
Great, 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 great.
Consider the fact that sometimes statistics don't really show good results. You know, the Oasis of Hope is not selecting patients. It's not cherry picking.
Correct.
When you're doing a clinical trial, you usually do optimal patients. You usually cherry pick. We don't do that. And when we, you know, statistically, if a patient is extremely sick and their prognosis is very dire, and it turns out that they live a year or 2 or 3 more than that expected, that might not show on statistical work, but you know it is clear evidence that the treatment will extend the patient's life, and we extrapolate. We extrapolate if it helps extend a patient who is in dire terminal situation. Obviously, it will help someone who has a full potential for recovery.
Perfect.
Yes.
Caroline has an interesting question, and it's something that we should openly discuss. We spoke about chemo, some benefit of chemo. I mean, you know, in this alternative niche that we're in terms of treatment, chemo is very maligned in a way. Why do we use chemo in some cases, in some cases not?
Well, we use low-dose chemo in a good number of our patients as a synergistic approach. And we've seen, we are in a race against time, and the patients come here with a tremendous amount of tumor activity. And so if you see it that way, the cancer is way ahead of us, and we need to level the playing field. Once we level the playing field, then natural therapies on their own can be very, very effective. Most tumors are quite aggressive, And if they're too far away, we need to put stumbling blocks to that tumor in order to level that playing field. And we've seen that with low-dose chemo, using a 5-FU derivative has proven to be very, very effective. And it has increased our results, our rates significantly since we started doing low-dose chemo in a good number of the patients, not all of the patients.
IPT, right?
But in IPT is different.
It's different, okay.
Okay?
Okay.
No, I'm talking about low-dose chemo. So yes, in some cases it is necessary, advisable, and very effective.
Chemotherapy is a bad word. We wish we would be able to use another word, but we're not using chemotherapy in the traditional sense. Chemotherapy is part of an approach, is not the approach. Chemotherapy is a helper element to our main therapies. In our setting, chemotherapy will not compromise life quality or immune status. Otherwise, if that was true, we would be shooting ourselves in the foot with chemotherapy. No, this is a novel way of doing chemotherapy, and it is pretty much a characteristic of the Oasis, because we're doing multiple elements together. And a very clear evidence of that is the fact that years ago, when we were using a drug at about 30% or less of the dosage, the doctors would criticize us and say, that's stupid, that doesn't work. But because it's part of an overall approach, it would work. Or they would say something like, why are you using that drug in this cancer? There's no support for it. Why? Because if we put it together with every other element, they will synergize. They will bunch up. And that we've been doing that for now, that after years, when we started using this approach in cancers such as liver cancer, or cancers in which these drugs were not established in the medical literature, now they are.
And also, let's say 10 years ago, they would consider our low dose completely a waste of time and money. And more, the normal dose is coming down to levels very close to ours. So now we're using conventional, in some cases, conventional amounts of chemotherapy that were considered ineffective and extremely low a few years ago. So they're coming to the conclusion that using it in a low dose is much better than in the conventional approach from some years back.
So review your concept. Review your concept. Chemotherapy, even now in mainstream oncology, not everything is cytotoxic. Not everything is the old style chemo. And you can't bunch up the new drugs with the old drugs. And you can't bunch up the Oasis approach with the standard cytotoxic chemotherapy. You have to be a lot more, discerning in regards to what we're doing. And we're calling chemotherapy because we don't want to do it, act as if we were trying to hide that. We don't.
Great. That hour has flown by. We're going to take a couple more questions and give Dr. Contreras and Dr. Cecena some time to rest. I wanted to say that we are giving away about 10 free books signed by Dr. Contreras and Dr. Cecena this time from both of you guys.
That'll add to the value of it. Yeah.
It's worth its weight in gold. You will get an email. 10 lucky winners that participated in today's webinar will get an email, and all you got to do is send us your name and address and to whom you want to dedicate it to, and we will be happy to send you a book. In the continental U.S., we get people from Singapore wanting. That's very difficult.
It's complicated.
Very complicated. Michelle Tucker, that's a great question. Can you educate people on the possibility of cancer recurrence after conventional chemotherapy treatment versus immunotherapy?
Yes, well, the possibility of recurrence is always there. And reducing that risk with a protocol like ours is very, very wise. So if you are in complete remission, or if there is no evidence of disease with a cancer that has a high possibility of recurrence, I would also encourage you to consider our protocol to reduce that risk significantly. I think I'm addressing the question correctly, right?
Yes, yes,
Okay.
yes. And,
Yes.
okay. I have to pick one more question. Let me see, let's go with,
Who's the lottery winner?
let me see, radiation. About soft tissue sarcomas? Yeah,
Soft tissue sarcomas are difficult tumors to treat. They're very aggressive. And since the inception of the dendritic cell-based immunotherapy, which is the term that we can use and not be blocked.
trying to get us into trouble, Dr.
Right.
Contreras, trying to get us into
Our results have improved, and we're encouraged to invite people to come for our treatment, and it's worthwhile trying.
I should make a note of that. I've been here for 32 years, and our first success against sarcomas was 25 years into my tenure here, and that coincided with the use of the vaccine therapy. So the vaccine therapy really made a difference. So
impact therapy.
where before
Impact therapy.
we would try to dissuade a patient from coming for that particular disease, now we know that we can offer a patient a relatively reasonably good chance that they have a fighting that can fight the disease.
Thank you. Okay, so thank you so much, everybody from all over the world. It's amazing how many people showed up and how many people stayed on. This is truly a blessing. And Monica, thank you. Can I set up an appointment without having all the tests? Yes, give us a call, send us an email. We also have a medical questionnaire online. If you fill that out and you're very detailed, we can probably give you a Zoom consultation or a phone consultation with one of our doctors and give you a good idea of what we can do here at the hospital. What is the name of your therapy? It's called IMPACT. Immuno-personalized autologous cellular therapy.
That's for the dendritic side.
Dendritic side.
But it's the Oasis of Hope protocol. Okay.
Yes. And last question. Thank you for all you do. I have breast cancer that has metastasized into 3 areas in the bone. Now I have a nodule on the side of my neck. This is Veronica. Now I have a nodule on the side of my neck. Lymph node is what doctor suspects. Is that treatable? Yes.
We have had very, very good success in patients exactly like yours. We would need to know what type of breast cancer you have, if it's hormone dependent or not. But at any rate, regardless of the type of tumor, we have been very effective in treating cases like yours.
Veronica says, "I'm seeing you soon, so she's probably going to be a patient with us pretty soon. So we'll treat you right, and we'll see you soon, Veronica."
Look forward to
Sheila,
good things.
I'm very interested in the book to learn more. Sheila, I will make sure that you get.
Yes.
If you can, send us an email at info@oasisofhope.com, info@oasisofhope.com with your name and your address, and I'll be sure to send you one. Thank you so much, Dr. Contreras.
Thank you all. God bless.
Thank you.
Always pleasure to see you. We'll see you in 2 weeks. 2 weeks. We're going to do it in 2 weeks. And if you have any suggestions of the topics that you guys want to know, send us an email, and we'll be happy to answer your questions and give you more information about the wonderful treatments that we offer at the Oasis of Hope. A lot of cancer wisdom in here. So thank you.
Thank you very much.
Doctor, al rato que empiece